So today's online lecture will be dealing with assessment, more specifically patient assessment. This is chapters 11 and 12 in your textbook if you'd like to follow along. I think it's most important to understand that patient assessment is a vitally important skill for an emergency responder to possess. It really does determine and tell you what emergency medical care your patient might need. And more importantly, if you do not properly assess the patient, then you cannot provide the proper emergency medical care that your patient might need. As a first responder, you will assess every one of your patients. So let's think about that. What I'm saying is that for every patient you will encounter, it will require some piece of assessment. Some of these assessments will be relatively simple, such as dealing with someone with like an ankle sprain or a wrist sprain, while others will become more challenging. So the purpose of this online lecture really is to get you familiar with the process so that you might be more efficient, accurate, and be able to adapt to individual patients. So in thinking about patient assessment, I think it's important for us to always establish a plan of action. And that plan of action really is what's called an assessment plan. And that assessment plan is composed of 6 different components, which you see listed below. But component number 1 is scene safety, which we'll talk about a little bit, but we also talked about this in our chapter 10 online lecture, so refer to that for more notes. The second step in the process of the assessment plan is the initial assessment. Third would be our physical examination, which we as clinicians should be really, really good at by the time we leave Point Loma. And then we have our fourth, which would be patient history, sometimes the most difficult portion of the assessment plan. Fifth would be the ongoing assessment, and last but not least would be the patient handoff, where we're giving the patient over to the EMS so that they can provide advanced out-of-hospital emergency care. So let's start with the scene size up first. So remember, we think about scene size up. Scene size up really begins with the personal safety of the first responder. And remember, we said a dead first responder is a no good first responder. And so we really do need to make sure that the scene is safe before we enter the scene. And so we think about personal safety. It really is comprised of 2 components. The first one is your BSI, or what we call your, it's called body substance isolation. Another way to think about this would be your PPEs, right? Your personal protective equipment. So that can include anything but not be limited to gloves. It could include masks, etc., right? So anything that would protect you from being exposed to a pathogen. And then the other component to personal safety is scene safety. Not only do we survey the scene to make sure it's safe initially, but scene safety is always an ongoing task. Even when we're in the midst of providing care for our patients, we're always surveying the scene to make sure that it is safe. The new addition to scene size up or scene safety has to do with the MOI and the NOI. The MOI is a lot different than the NOI, and here's why. The NOI or the MOI refers to the mechanism of injury, and the NOI refers to the nature of illness. So when we describe someone who has some type of injury, like a fracture or a strain or a sprain, we would want to know how they did that. That would refer to the MOI, the mechanism of injury. However, if we encounter a patient who is sick or is ill or has the flu, is coughing, is complaining of chest crushing pain, who we suspect has some type of heart attack, then we would refer to this as the nature of illness. So these 2 components, even though they describe what happened to the patient, they describe what happened to different subsets of patients. And then last but not least in the scene size up are the necessary resources. Remember, we talked about knowing the cross streets, knowing the number of patients. This will help determine what necessary resources are needed. Is it the fire department because there's a fire? Is it a police department because we're dealing with patients who are violent? Or is it that we need multiple EMTs or paramedics because we're dealing with lots of patients? So the necessary resources really help determine who is going to arrive at the scene to help you in your emergency situation. So once we've got the nature of the illness or the mechanism of the injury, and we've got our necessary resources, we've then completed what we would call the scene size up or scene safety. Once we're done with scene safety, then we kind of go back to the drawing board, right? And when we go back to the drawing board, what we can say is that, okay, we can check off scene size up. We've sized up the scene. We've made sure it was safe. We determined the number of victims that are involved. We determined the number of resources that we might need. And it is then and only then that we go to the second step in the process of the action planning, which is the initial assessment. So when we think about initial assessment, we're really going to think about several steps within it. And the first step is the general impression. The way I equate the general impression is really to meeting someone for the first time. What do you do when you meet that person? You kind of check them out, look them up and down, and you form a generalized impression. So when we think about general impression as it relates to assessment planning, we have to think of two different things. The first one is the chief complaint. And so what we're saying is, what is this patient complaining of? What are they reporting? What are the signs and the symptoms that they're telling us? Is there pain? Is there numbness and tingling? And then another way to state this would be, why did the patient call 911, right? That would be their chief complaint. What made them call? Once we've determined that, then we have to go back and we have to figure out what is the nature of their illness or the mechanism of their injury. And so we have to categorize our patients into one of two categories, either their trauma or their medical. And someone who's a trauma patient is a little bit different than someone who's a medical patient. A trauma patient is someone who has suffered from injury, and a medical patient is someone who suffers from the illness. Okay, those are different patients. They get treated differently. So someone who is a trauma patient and who has an injury, what we're really going to do in the process of our examination is we're going to spend a lot of time in the physical examination part, where we're touching our patient, we're having them move, we're trying to determine what is the extent of the injury. However, with a medical patient or someone who's suffering from some type of illness, we have to really spend a lot of time in the history portion of our examination to determine what led to the illness that the patient might be experiencing at that moment in time. So our general impression really allows us to get familiar and acquainted with our patient before we actually start to put our hands on them. So after we formed a general impression, the next step in the process is what we would call the determining the responsiveness of the patient. Okay, so think about responsiveness. What we're going to talk about are the levels of consciousness or LOC. So we would say levels of consciousness and or LOC. So levels of consciousness / we'll say responsiveness if you want to say that too. And there are 4 different levels of response. So when we think of someone who's an A, we think of a person who is what we call alert, okay? Someone who is alert, a patient who is alert and is responsive and is oriented. So what this means is the patient is aware of his surroundings, the appropriate time and the date, and they know their name. This is commonly referred to as being responsive to person, place, and date, or what some people in the field would call oriented times 3. So again, what we would say with someone who is an A on the levels of responsiveness is that this person is totally aware of his or her surroundings. They know this checklist here. They know what happened. They know their name. They know who they are. They know what date of the week it is. Now, if we encounter a patient who is not alert, then the next step is to figure out how unalert they are. And so now we'll start talking about specific orientations. And the first one is a person who is disoriented and only responds when spoken to. So we say that he or she responds to verbal stimuli. And then we would also say that the patient is capable of answering questions about the place and date, but they are incorrect. So they can respond to you, but they really don't know where they are. They really don't know the date. So this patient, sometimes when we encounter them in the field, they may be lapsing in and out of consciousness, right? So you ask them a question, they become conscious, then they go back into unconsciousness. And what we would say is this person is oriented times 2. And again, we're going to say that the V here stands for verbal, okay? The next stop on the responsiveness train is a person who only responds to what we would call verbal stimuli or painful stimuli, And so when we think about painful stimuli, what we're going to think about is the patient who only responds when we maybe, let's say, pinch them on their earlobe or above their collarbone. So they only respond when you actually pinch them. This patient does not answer questions or open his or her eyes or respond to verbal cues. He or she can really only stares into space or flinches, and so we may pinch them, or we may rub their sternum in the absence of chest injuries, and so they respond to verbal to painful stimuli. So this person would be what we consider painfully alert. And then the last level of orientation, probably the worst level of orientation, is a person who, that last level of orientation would be someone who is what we would consider unresponsive or unconscious to any type of stimuli, whether that be verbal, whether that be painful. So how do we confirm this? The first thing we want to do is we want to gently tap and shout and just say, "Are you okay? Are you okay?" And typically with an unresponsive patient, you will not get any response whatsoever. And so why do I say gently tap and shout? Well, what happens if you encounter a person who's sleeping and you don't tap and shout? I've had the case where you've had a person sleeping on a park bench and someone calls 911 because they panic, and then EMS arrives and they say, "Oh, well, they're just sleeping. We tapped them and they woke up." So you don't want to be that person who jumps the gun. So always tap your patient and ask them if they're okay. If you get no response, then they're considered to be unresponsive. Now, what do we do in the case of a child? It's a little bit different. We don't tap and shout. Instead, what we do is we rub the bottom of their feet, and then if they don't respond, they would be considered unresponsive. So again, do not tap and shout because infants are a little bit more fragile in nature. So these are the 4 levels of responsiveness. Again, we have alert, we have someone who's responsive only to verbal cues, we have someone who's responsive to only painful cues, and then last but not least, we have the person who's unresponsive to both verbal and painful cues. So that brings us back to the initial assessment. We've talked about the general impression, where you're looking at the chief complaint and determining whether or not they're a medical or trauma patient. We've looked at the responsiveness, whether or not they have their 4 levels of alertness. Are they alert? Are they alert to verbal, painful, or are they completely unresponsive? Once we determine the levels of responsiveness, the next step on this journey would be to assess their vitals. And the first aspect to vitals is the airway. And so with the airway, what we want to do is determine whether or not the airway of an unconscious victim is open. If the airway is closed, I think it's obvious that our patient wouldn't be able to breathe. And so as a first responder, one of our number 1 roles is to recognize whether or not the airway is open. And then if it's not open, then we have to figure out how to open that. And we do that with a head tilt chin lift. So one of the questions that I ask is, how do we open the airway of a victim with no head, neck, or back injury? Well, the answer to that question is with the head tilt chin lift. Okay, so we're gently going to put 2 fingers underneath the mandible of our patient and lift that chin up to the ceiling. And that typically will open up the airway for our patient. However, if we do have a patient that we suspect has a head injury, then we have to use this technique here, which is called the jaw thrust technique. And we'll do this in lab, but the jaw thrust technique is a technique in which the mandible of the chin is thrusted forward without moving the cervical spine. And so when we open the airway, we're going to breathe into our patients. Now, here's the big deal. Sometimes air may or may not go in, right? And if it does not go in, that means one of 2 things. Either you as the first responder didn't open the airway back far enough, or it may be that the patient has what's called an obstructed airway, where they might actually be choking on something. The number 1 obstructor of the airway is, can you guess? Yep, it is the tongue. Okay, so we want to open the airway, we want to breathe into our patients, and we want to confirm that air is going into our patients. If it's not, go ahead and re-tilt the patient's head and try to open the airway again. So after we've opened the patient's airway, the next thing that we have to do is we kind of have to breathe for our patient, right? Assuming that our patient is unconscious, the next thing that we want to do is we want to breathe, or at least assess breathing in our patients. And so when we assess our patients for breathing, what we want to assess is the rate and the quality of breathing. Is it regular? Is it quiet? Is it effortlessly, right? Otherwise, if we have encounter the case where our patient is either breathing too fast or too slow, we need to assess that, right? Within the the adult community, the normal breaths per minute are about 12 to 20 breaths per minute. Your 12 breaths per minute would be on the lower end of the spectrum, and that's going to be for your patient who is active, so like your athletic population. And then your 20 breaths per minute is just going to be your normal adult community, someone who may walk once or twice a week, or just your normal adult. And so when we assess breathing and the rate of quality, we have to assess this by looking at our patient's chest. We want to look for the chest to rise and fall. One of the rules of thumbs when we're counting breaths is to not let your patient know that you're doing that, because if you've ever gone to the doctor and the doctor says, okay, go ahead and breathe, and I'm just going to look at your chest, you start to change the way that you breathe, or you start to alter the way that you breathe, and you don't want your patient to do that. And so when we're counting one breath equals the chest rising and falling. That would be 1, right? We can do that for 15 seconds, and we can multiply the number that we get by 4, and that would give us our breaths per minute. So what are some signs and some symptoms of abnormal breathing? Well, there are many. I give you the most common, which would be a patient who has noisy breathing, a patient who is either what we would call hyperventilating or hypoventilating, a patient who also has pain with breathing. So they might have some type of, like, let's say, rib fracture that's compressing on and causing pain with breathing because it's pressing on the lung. And so we really want to get a good assessment of breathing, and the only way to do that is to assess breathing, the rate and the quality of breathing, without our patients knowing it. The last vital that we're going to assess on our patients is circulation. So let's talk about circulation. Circulation is the assessment of blood flow throughout the body. We want to make sure that the heart is pumping efficiently and effectively, because if not, then our patient has decreased blood flow and decreased oxygen to the area, which means that cells could begin to die. So when we check a pulse, typically the average adult pulse is about 60 to 80 beats per minute. Our athletes could be lower, on the lower end of the spectrum, about 50 beats per minute. And then children and infants tend to have higher heart rates, and that's because their body's working more efficiently and fast to pump blood to their small body. And so a child would be about 80 to 150 beats per minute, and then an infant could be 100 plus beats per minute. So do not be alarmed if you are checking the pulse of an infant or a child. It should be pretty high. When we think about what would be some signs or symptoms of an abnormal pulse, the number 3 signs and symptoms would be a pulse that is weak, and what some people refer to as tready, which is the inability to really feel it. It could be irregular, so it could beat regular for a few minutes and then start pulsing and beat really fast. Or the most common one would be a pulse that's extremely fast or extremely slow. And so how do we know if it's extremely fast or extremely slow? Well, we need to be acquainted with the normative values for adult athlete, children pulse rates. Now that brings us to another issue, which is, where do we check the pulse, right? So most of you probably know the most common place to check the pulse would be at the radial side of the hand. However, it really does depend. In adults, if they are conscious, we're going to check it on the radial side of the hand. But if they are unconscious, then we check it in the carotid pulse, or in the neck. So this picture down here that you see is where we would want to check it if they were unconscious. In infants and children, the recommendation is to always check it in the brachial pulse. And again, if they're unconscious, if it's a child, we're going brachial pulse again. If they're unconscious and they're adult, again, we're going to go to the carotid. And we'll practice on palpating each of these pulses in lab during the next class period. One big thing to keep in mind when you're checking a pulse is you never ever want to check a pulse with your thumb, because obviously your thumb has a pulse in it. So typically the rule of thumb is to check it with your index finger and your middle finger, or digits 2 and 3. Another component to circulation is skin characteristics. Remember, I said that if you have less blood flow to an area, your cells start to die off and you have less oxygen. So we have to figure out what the skin would look like. So the first step in assessing skin characteristics really is to assess the skin temperature. And the easiest way to do that I've learned is using the back of your hand. Apparently the back of your hand is always at room temperature. So if you were to put the back of your hand on your patient's forehead, if it felt warmer or cooler, then we would know that they either fall above or below the room temperature, which could indicate a problem on either side of the spectrum. And then when we look at skin characteristics or colors, the two most common skin characteristics that we get are your red and your pale. Okay, so your red would represent the body working harder, so we would say increased blood flow, and then the pale would represent your circulatory system working slower, and we would say this person's probably getting decreased blood flow and decreased oxygen. Either end of the spectrum we're concerned. In this case, we're concerned about maybe some heat pathology or heat illness, right? And then on this end of the spectrum, we're worried about maybe your patient losing blood. And so either way, it becomes a problem for the first responder. So one way to assess blood flow in the field is to use the capillary refill. And so the capillary refill really represents the amount of blood flowing to the capillary beds. And so what we want to do is we want to take the nail bed of our patient and we want to compress it for 2 seconds. And then we want to release it. And typically what happens when we press the nail bed and let go is you would expect that nail bed to refill and to recover its normal color. However, in a patient who has decreased blood flow to the area, it will take longer than 2 to 5 seconds to fill. And so in that case, if it takes longer than 2 to 5 seconds to fill, then we would say that's a positive cap refill. That patient they have decreased blood flow to the area, and that's a medical emergency. One area of concern is females, because we do wear fingernail polish. In that case, you can either use the toenails or you can scrape off the fingernail polish to get a capillary refill. So one other area of concern, which is dealing more so with head injuries and blood flow and circulation, is looking at the pupils and assessing the patient's pupils. And when we do this, we really use an acronym called PEARL. And PEARL, what PEARL stands for is the P represents pupils, the E represents equal, the A represents active, the R represents reactive, and the L represents light. And so what we say with PEARL is that we want to assess whether or not the pupils are equal, active, and reactive to light. And so how do we do that in the field? It's very simple. Either we can cover the eye that we're testing with our hand, make it dark, and then move our hand. And what we would expect is that the pupil would vasoconstrict when we add light back into the environment. But here are some things to look at when we're in the field and we're wondering whether or not our patients have some type of head injury, what the pupils might actually present like. And so let's go ahead and take a look at this. So the first patient that we would have is a patient who has vasoconstricted pupils. So what I mean by vasoconstricted is that the pupils, as you can see here, are relatively small. This could be an indicator of some type of head injury. It could also be an indicator that the patient is abusing and or using drugs that would cause vasoconstriction. So this is one type of pupil setup that you might have in the field. The other type of pupil setup that you might have is what we call fully dilated or fully blown pupils, where these are the pupils are very large in nature. And so what we might say here is that this patient might maybe be an alcohol abuser, or might have taken some type of sedative that caused the pupils to fully dilate. And then the last pupil setup that we might actually see is this one right here, where you have one fully blown pupil and one vasoconstricted pupil. In this case, if we see this in the field, we're worried about a head injury, a traumatic brain head injury. Traumatic injury. And this is a medical emergency. We want to call 911 right away if we can. Okay. So in the initial assessment, we've talked about the general impression, we've talked about the responsiveness and the 4 levels of consciousness. We've just assessed the vitals. We've talked about opening the airway. We've talked about the normal breaths per minute. We've looked at the circulation and what patients should present like. Now what we're going to talk about is updating the EMS system. So in the scene safety part of this lecture, we've called 911 and we've initiated the system. And now within our initial assessment, we've formed the general impression. We know how many breaths per minute. We know whether or not they're breathing. We know whether or not they have decreased blood flow. And it's at this point in time where we're actually going to call 911. So we're going to call them back and we're going to give them an update. Okay. Why is this important? Because it might change what they are prepared to do when they arrive to the scene. So overall, these 4 steps encompass what we call the initial assessment. So we've talked about scene safety. So we've talked about scene safety, and we said we're going to size up the scene, we're going to check on personal safety, we're going to determine the mechanism of illness or injury, and then we're going to determine the necessary resources, right? We've talked about the initial assessment, which really is comprised of forming the general impression, assessing vitals, determining the levels of responsiveness, right? So we've got those two checked off. The next step, which is the fun step for me, is the physical examination. And so we're going to talk about physical examination because this is the bulk of what we'll do as first responders. So the physical examination is that you actually placing your hands on the patient and being interactive. So it is very systematic, just like the initial assessment is. It is a systematic process that should always be performed in the same manner every time. Part of being systematic is what we call DOTS, and DOTS stands for deformity, open injuries, tenderness, and swelling. So what we are saying with DOTS is that we really truly want to make sure that we do not miss anything. So the best way to be systematic is to always check the injured area for deformities, to always check the injured area for open injuries, to always touch your patient and determine where they are tender, and to look for any swelling that might be around the injured area if in fact we are dealing with an injury. So with that being said, the physical examination really looks something like this. So if we look at the physical examination, what we would say is that physical examination involves an examination of the entire body. We should always start the physical examination at the head of the patient. The only exception to the rule when it relates to starting the physical exam at the head is when it's a child. When you have a child, starting at the head could make them more afraid and more timid. So the recommendation is that for a child that you actually begin at the feet and then work your way up. So that way the child learns to trust you as you begin your physical examination. Otherwise, we're going to start at the head for most patients, and we're going to examine the head. We're going to check the head for any neck injuries, and then after we've checked the neck for any neck injuries, we're going to move to the chest, and then we're going to check the abdomen. With the abdomen, we really want to do what's called a quadrant assessment, but we'll talk about that later when we talk about abdominal injuries specifically. And then after we're done with the abdomen, we're going to move to the back. Now, when I talk about moving to the back, I'm not referring to rolling your patient over to do the assessment. It's a simple assessment if your patient is lying on their back, to just kind of sneak underneath with your hands and to palpate the back for any pain. With the pelvis, what we really want to rule out is a fracture. So we're going to do this in lab, but we're really going to compress the pelvis. And then last but not least, we want to assess the extremities of the patient, so the legs and the arms. Now, my rule of thumb with assessing any type of injury is that you always start on the uninjured side. Why do we start on the uninjured side? Because we really don't want to cause pain to our patient, do we? I don't think so. So we're going to talk about these steps a little bit more specifically so that you know exactly what to do in a physical examination. So as I've already stated, we're going to begin at the head, and the big deal with the head is to look for any clear fluids that are coming out of the ear. If they are coming out of the ear, then what you suspect is that you have some type of head injury. If there's clear fluid, what this indicates is cerebral spinal fluid, and that means you have a spinal cord injury. After we move from the head, we're going to go to the neck, and the big deal is to sweep your patient for spinal injuries, more specifically C-spine injuries. Then we'll go to the collarbones and the shoulders, and what we're looking for again is we're going to be using DOTS: deformities, open injuries, tenderness, and swelling. Once we've ruled out DOTS, so there's no deformities, there's no open injuries, what we're going to do is we're going to have our patients shrug their shoulders just to make sure that they have full function and capability of the shoulders themselves. After we move from the shoulders, the next step in that process, can anyone guess? No? Okay, well, fine. It would be the chest. What we're going to do with the chest is we're going to have the victim take a deep breath in. So we're going to take a deep breath in, because if they can do that, then that kind of rules out a fracture if there's no pain of the ribs. And then we're going to have them exhale, and then we're going to squeeze around the rib cage. to rule out fracture, and we're going to palpate the ribs for any deformity. So again, we're doing dots. In the abdomen, what we want to do first and foremost is ask them if they have any stomach pain, and then we're going to palpate what we call the 4 quadrants. Again, we'll do this in a lab, so I'm not going to go into detail here. One thing to recognize is that obviously it's like the Pillsbury Doughboy. You want the abdomen to be soft. You do not want it to be rigid. If it is rigid, then what we suspect is some type of internal bleeding within the abdominal cavity. And that is a bad thing. It's a medical emergency. We'll talk about it when we get to abdominal injuries. So after the abdomen, we're moving into the pelvis, and with the pelvis, we want to rule out a fracture. So what we're going to do is we're going to push down on the most bony portions of the pelvis. If there's no pain with the push down, then we've ruled out a fracture. However, if there is pain, then it's possible that they have what we consider to be a pelvis fracture. Then moving from the pelvis, we go back into the extremities, so the arms and the hand. Remember, with the arms, and specifically with the hands, if we want to check blood flow, remember we're going to do the cap refill here. This is where we would do it in the physical examination. Always, 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 as I said, check one extremity at a time. And remember, we always want to start on the uninjured limb first, working our way to the injured limb after and only after we've touched the uninjured limb. And then if our patient can, as long as there's no bones protruding, we can have them move their arms, squeeze your fingers to do a grip test, just to make sure that they have function of their extremities. We can have them wiggle their toes and press on the gas pedal. So with the legs, what we're going to do is we're going to look and feel each leg, and those are going to be the foot and the toes. And if our patient can bend their knees, awesome, have them do it. Wiggle their toes, as I said in the previous slide, and we're also going to have them press on the gas pedal, either one. If we can't get a cap refill in the hand, then obviously with the toes, we want to get a cap refill just to assess blood flow. And then last but not least, the back. If the patient is laying on their back, we're just gently going to reach underneath the patient's back and palpate and sweep accordingly. However, if our patient is face down when we come to the scene, the first rule of thumb is that this is the only time your physical examination can go out of order. You're going to go ahead and you're going to palpate or touch or sweep the back first, and then you're going to go ahead and flip the patient over and start from head and work your way all the way down to toes. This is the only time when a victim is face down that we kind of start our physical examination out of order. Otherwise, unless it's a child, we always start at the head. So we've done our scene size up. The scene is safe. We've performed our initial assessment. We formed a general impression, signs and symptoms. We've updated EMS. We've performed our physical examination. We now know what is painful. And now it's at this point in time that we get to patient history. So what's patient history? Patient history is truly just asking our patient about the incident and existing injuries and or illnesses. And the best way, the most succinct and efficient way to take a patient history is with what we call sample. So what does sample stand for? Well, the S is going to stand for what we call signs and symptoms. The A is going to stand for allergies. So any allergies to medications and or dust mites. The M is going to stand for medications that they currently are taking or have taken in the past. The P is any past pertinent history, so past history of any injuries or illness that might relate to the current injury or illness that they have in the emergency medical field. The L is last oral intake. Well, why might this be important? If our patients are going to go into surgery, it's important to know when they last had food, because if not, the physician will not operate on them if it was fairly recent. And then last but not least is E, which are the events that led up to the injury or the illness. Or another way to say it is the mechanism of injury or the nature of illness. So the events leading up. If you do this every time, if you take a sample on your patient, you will not miss anything in the history portion of the initial assessment. So again, sample stands for signs and symptoms. Ask them what are they feeling. Ask them if they have any allergies to medications, if they're currently taking any medications. Like for example, with a patient who's had a head injury, if they've taken aspirin, our biggest concern is that their blood has been thinned and we need to get them into the emergency room right away. Do they have any past history of head injuries? Did they? What was the last thing they took? Did they eat pizza? Did they eat Ortiz's carne asada burritos? What did they eat prior to the incident? And then last but not least, what were they doing, events leading up to? So what were they doing before they were actually injured or became ill? So the ongoing assessment is step 5 in the process. It occurs right after the history taking process. And so what we want to do is we want to perform an ongoing assessment. So this is after we've treated everything in the physical exam. What we want to do is we want to start to treat anything that we've observed. So for example, if we notice that there's an open wound and it's bleeding, we're going to start putting on and applying bandages to control the bleeding. We want to call 911 during this time. If we have a patient who we need to do a more thorough physical exam on or a more thorough history on, then this is the time that we want to do it. Otherwise, we do not need to repeat it over again. Only time we repeat either a history or physical exam is when we were not thorough enough to get the answers that we needed. One of the big things about the ongoing assessment truly is that you have to record everything, whether it be in your brain if you have a good memory, or writing it down. So here we go again, building up that trunk. Go ahead and put a notepad and a pencil or a pen in your trunk so that you might have something to write down, specifically your dots, right? Deformities, open injuries, tenderness, and swelling, and also your samples, your signs and symptoms, allergies, medications, past pertinent histories, last oral intake, and the events leading up to the injury. This will help you report when we get ready to hand off the patient to EMS personnel. Okay, so after we've began our ongoing assessment, one of the biggest questions is really, when do we need to call 911? When is there a need to do that in an emergency situation? Well, when you're in doubt and you're unsure whether or not you're supposed to call 911, here's a good list of reasons to do so. First of all, a person who is unconscious or altered LOC. So that would be the patient who only responds to painful stimuli or verbal stimuli. You want to call 911 right away. Person who has persistent chest pain because we suspect heart attack, right? Person who has no pulse, again, because it has to do with cardiac arrest. Person who has seizures, specifically if it's their first time having a seizure, in any painful, swollen, or deformed areas that we encounter, we want to call 911. Now, there is a lengthy, exhaustive list of other pathologies, and you will know when you need to call 911. Sometimes it's simple. We bandage them up. We can take them to the emergency room ourselves. But if it's traumatic, if it's catastrophic, then we need to call 911 so that they can get the help that they need. So when you call 911, what are you going to give to them? First of all, you're going to tell them where the emergency is located. So again, that requires you to know your cross streets. You want to give them your telephone number because sometimes dispatchers do not have caller ID. So you want to make sure that you give them your phone number, obviously your name, which some people forget. You want to tell them what happened. So the mechanism of injury and or the nature of illness. The number of patients involved or people involved, because again, remember, this is going to help dictate how many EMS service providers come to help you out in your situation. The condition of the victims, again, all of this should sound very similar. It is basically your sample. The only thing that you want to add in there is what care you have already given so that EMS knows when they arrive where they need to begin or to pick up. One rule of thumb is to let the dispatcher hang up on you. When I was working the football event, I was my second year certified, I called 911 because I had a patient who was complaining of severe heart pain, and it turned out that he was 16 years old and he was having a heart attack. And I called 911 and I need someone here right away, please. I have a patient who's having a heart attack. And so the dispatcher's like, okay, we're sending someone. And I automatically hung up because I heard sending someone. So my phone rang 30 seconds later and I didn't recognize the number. And I answered, I said, hello. And she's like, this is the dispatcher. You didn't give me this, this, and this. So from now on, the rule of thumb is to let the dispatcher hang up on you. Never hang up on a dispatcher because they might have to call you back. And you don't want that to happen. Trust me. Okay, so what are you going to do while you're waiting for EMS to arrive? The big deal is to do no further harm, to try to keep your patient from going into shock, so getting chilled or overheated, because they may go into shock depending on the extent of the injuries. You really want to put your person or your patient in a comfortable position. Typically, we call that position the recovery position, which is a position where your patient is on their back with their legs elevated above the heart to increase blood flow and to help the heart with recirculation of blood throughout the rest of the body. If you can, it's at this point that you want to repeat your initial assessment, and if you need to, again, your physical examination. And then you're just going to keep providing care and bandaging and treating your patients for the things that they need until EMS arrives. One of the questions always is, how often do you check or reassess a patient. If the patient is a critical patient, you reassess that patient every 5 minutes. However, if your patient is alert and conscious and responding to verbal cues, then you would reassess that patient every 10 minutes. So you can see that your work isn't over once you've treated. You're always reassessing your patient because you never know when your patient can start to go downhill. So this kind of brings us to the end of our lecture. I think it's important to just do a good recap of what we've talked about sizing up the scene. We've talked about the initial assessment. We've talked about the physical exam and how systematic you have to be. We've talked about the importance of history with a sample and being thorough and efficient. Talked about our ongoing assessment, which is an assessment that occurs every 5 minutes with a critical patient, every 10 minutes with a patient who's alert and responsive to your cues. And the last step in this process is the patient handoff process. This is the process that most of us look forward to because it's that point in time where we hand off our patient to EMS personnel, and our job is, for the most part, it's over. So let's go ahead and talk about the patient handoff. So the patient handoff includes a handoff report, which is why I said it's important that you put some type of notepad and pen in the back of your trunk. What it's going to include is specific patient information and information from your patient assessment. So the first thing that you always want to note is the age and the sex of the patient. Remember your chief complaint. We're going back to the initial assessment portion of that. We need the levels of responsiveness. Are they alert? Are they verbal, painful, unresponsive? Then we're going to our ABCs, or what we consider this to be the vitals, right? Our physical examination findings, our patient history, or what we would say is the sample, and then any care that you've provided for your patient. And so step 6, last step, you're handing your patient off, you're giving the EMS or the paramedics or the EMTs something to go off of. And what this something is what it's called your handoff report. It should include all of this patient information. It is at this point in time that you are pretty much done with your patient treatment, right? And so rule of thumb is to let the ambulance leave before you leave the scene, so you're not sued for abandonment. So this brings us to the end of our online lecture. As always, there will be a quiz posted on eClass, and we will go into lab for the next time that I see you guys. I'm super excited about performing the physical examination and doing some patient case studies with you guys. Looking forward to the next online lecture. As always, God bless.